everyone, and welcome to anyone who's new to the session. Just to begin with some housekeeping as per usual, just to let you know that this Zoom meeting will be recorded. We just ask that you remain muted whilst you're not speaking. And unlike last time, you can leave your cameras on if you are speaking when we discuss the case studies later on. But when you do unmute yourself and you do have the video on, try and make sure you don't have any background noise or anything like that, so you can be clearly heard and everyone can understand what you want to say. As we said before, just pop any questions you have down on the chat, and we'll keep an eye on that whilst Imran is going through the case presentation. I know Imran sent the case out this morning, but if you weren't able to access that, it's not a problem. You can still contribute just as you go through the case. As we go through the case, it just means that you didn't have very much time to prep. That's okay, because sometimes we don't get that much chance to prep for a case, or when we see patients, and you know, off the cuff is still fine. Did you have the next slide, Imran? So today we're just going to have a quick recap on the salient points of what an SMR is, and then we're going to go through the case. Well, Imran will present the case study for us, and then we'll all have this discussion as to what we should do for this patient. So it should be very interactive. I look forward to you all participating today. Just a quick reminder where you might want to go to look for patients to do SMRs. So there are a number of search tools that you can use. So we showed you Eclipse Live last time, SMR Live, which is our recommended one. But you know, there is the Electronic Frailty Index, Princer, the polypharmacy dashboard on EPAC, the Arden searches, the KEG searches, and obviously your MDT meetings and clinics. But whatever search you do, the most important thing you must do if you've done an SMR is record that you've done an SMR, and ensure that you've either put the read code or the SNOMED code in correctly. So we've just highlighted what the codes are. And just pick a template that you like to record your SMR in. We're not picky how you record your SMR either. Next slide. And things that we would expect you to consider in almost every SMR that you do is, you know, assess whether the patient has capacity to be involved, and if not, you know, you may want to get whoever's got power of attorney or next of kin involved in their conversations. The patient has to be key to an SMR. So I've had lots of questions about, can I do it with the nursing staff at a care home? No, that doesn't count as an SMR. Has to be somebody that's advocating for the patient if they're not able to advocate for themselves, and it's unlikely to be the nursing staff because they would be classed as a healthcare professional, just like you would be. Allergy status, it's always important to check that at the beginning of your SMR, good practice. You know, again, not in a non-confrontational way, checking whether they're able to take the medications that are prescribed to them. Incontinence status, because that has a massive influence on what you might prescribe, what you might not prescribe. Again, diet, fluid, swallowing status. We want you to be able to check their falls risk, their frailty risk, whether they're mobile. All those things are really important, because medicines have a big impact on those kind of things. And take the opportunity, because this is going to be a face-to-face review in a lot of cases, to do observations that you wouldn't be able to do if you didn't have the patient in front of you, like pulse, BP, height, weight, you know, get those in. Check smoking status and, you know, alcohol status. And then, you know, check if they've been giving meds without them knowing, so covert administration, and if that's happening, whether the appropriate documentations are in place, your mental health capacity assessment, best interest meetings being done, all those things. Check bloods and any investigations, and you know, this is good time to double check any interactions, any drug reactions, checking against whether it's appropriate for the renal or liver function. And also, revisiting some scores that you might have to do, like the CHAD-VAS, if you're thinking about stroke prevention in your AF patients, the ORBIT score for bleeding risk, which is now recommended instead of the HAS-BLED in your NICE AF guidelines, your Q risk for, checking whether you want to give somebody a statin maybe or something like that. So all of these things should be done as routine almost in a SMR. And then just a quick reminder of some places you might want to go and visit some really good tools that are out there and some really good guidelines. So we've just popped that slide back in just as a reminder of where you might want to go. Over to you.
Thanks, Rima. So let's get stuck straight into it, into the nitty-gritty of this. So what we have here is a female, South Asian, 77 years old. They had a neck of femur fracture, so it's a hip, 2016. They've been a type 2 diabetic since 1998. They've had hypertension since 1994. They have chronic kidney disease, stage 3B. They were diagnosed with atrial fibrillation in 2019. They've been suffering with incontinence since 2015. They're coded as severely frail, and there are no known drug allergies. So what are they on? So on their repeat, and they last had a 2-month supply. The prescriptions were issued in June 21. So just, last month. They're on the Tamil 100 milligrams, Ramipril, max dose, indapamide, amlodipine, solifenacin, alendronic acid once a week, cetraben cream, metformin, linagliptin, pioglitazone, max dose. They're on insulin, and they tell you at the SMR they're currently using 14 units in the morning, 18 in the evening. They're on the iCal, aspirin, atorvastatin, and rivaroxaban. On their acutes, they've got Canesten cream, which was issued a long time ago, Dactacort issued quite a while ago. They've got glucose testing strips, a box of 50, Lancet, paracetamol, which they get quite frequently, Flexitol cream. They've had one Pfizer vaccine back in December 2020. They've got Voltrol Emugel, amitriptyline 10 milligrams at night, and Senna tablets 2 at night. So, investigations. So they had their bloods done last month, and then they had their foot check annual diabetes review face-to-face with the HCA last Friday. They've got BMI of 38. Their EGFR was 33. Creatinine was 136. Potassium was 5.2. They have a protein creatinine ratio of 112. Their LFT was within normal limits. WNL is within normal limits. I'll put that in because some GPs, some doctors like to write WNL. And I remember asking the doctor, what's WNL? So you may see that. The only thing that was raised was the ALT at 77. Their blood pressure taken in clinic was 155/91 right side, then 150/88 on the left side. Then the third reading was 144/87 back on the right. And then standing, their blood pressure was 141/84 done in the left arm. Pulse is averaging around the mid-50s, early 50s, and is regularly irregular. Last HbA1c was 84. Cholesterol was 4.4 with an LDL of 3.2. Triglycerides were 3.3. HDL was 0.93. Patient was not fasting when they went for their blood test. Full blood count showed a hemoglobin of 87, platelets of 180. The mean cell volume was 75. Everything else was within normal range. They went for their diabetic eye screen last year in March 2020. The right, they've got R1 in both eyes. Now, if you don't know what R1 is, so let me explain that. So R0 is no retinopathy. R1 is mild, moderate retinopathy. R2 is quite advanced retinopathy. So we measured that. So it's R0, R1, R2. So they have retinopathy in both eyes. And M0 and M1, that relates to maculopathy, which is fluid buildup in the eye. So they've got some fluid buildup in the left eye, but the right eye is okay. Foot check, nothing abnormal. Everything was fine. Pulses were there. Foot check was done. Sensitivities there. Okay, right. Let's go on to because we've got the data there, we calculate their creatinine clearance, and their creatinine clearance has come in at 45 mils per minute. All right, history. So they came in last Friday for their annual diabetes check, and you've seen the results there. They've got some ankle and leg swelling, and the skin's very dry. They tell you they do get short of breath when they have to exert themselves a little bit, but at no other time. They do feel tired all the time, though. And again, I've put the abbreviation in, just in case you see this abbreviation in surgery. Doctors use this quite a bit, TATT, tired all the time. That's all it means. She doesn't walk very much. She's very sedentary. She's complained that she's getting 2 or 3 hypos a week, but there's no pattern. She may get it in the morning, she may get it late, she may get it in the afternoon. She's particularly complaining of itchy skin, especially the legs and the arms. Foot check, as I said, there was no problem. She's not doing any blood glucose monitoring at home. She has got a machine. Doesn't drink alcohol, has never smoked. She passes urine frequently. It does dribble. She does, when it comes, it dribbles, and she's getting dribbles in between as well. What this means is if she is thinking of going out, she won't drink. She'll avoid fluids because she doesn't want to be caught short when she's out. She's got a little bit of constipation. She's going, but it doesn't feel like a full bowel motion, and she uses Senna for that. So you have a quick look at her legs and her ankles, and she has got what we call pitting edema, and you can press firmly, and it does leave a nice little indentation, which then comes back up slowly. And when you're having this conversation with this lovely lady, she says, I always take my medicines. Occasionally, I won't take insulin. If I haven't eaten too much, then I don't want to get a hypo, so I'll avoid the insulin. Do forget the statin occasionally. And when you're looking at your EMIS screen, she hasn't had a prescription for the calcium vitamin D since December 2020, and the usage is showing up as 12%. February was the last time she ordered a statin. She hasn't ordered a rivaroxaban since December 2020. And again, with the insulin, bit of a mixed picture. Usage is showing up 47%. She's last had it in February 2021. She does use quite a bit of Cetraban cream now. And then you have a chat with the patient. What's worrying you? Well, she's worried about her puffy legs and ankles, which has been there for a little while now, maybe a few months. She has a lot of trouble sleeping. She was prescribed amitriptyline 10 milligram, but she openly admits, I never took it. Don't like sleeping tablets, so I thought I'd try without it, but she can't get to sleep. Meds are all over the place. Unfortunately, sometimes when she orders stuff, 3 things come in and she hasn't got 4, and then she has to put another repeat in for the 4, and it's just becoming bothersome for her. You know, why can't I have it all in one hit? She's also worried about her dribbling and incontinence problems. She was referred to urology last year. Year before, not last year. With a hospital letter from August 2019, where they recommended mirabegron, but that's not been initiated. That hasn't actually happened. And she was given a follow-up appointment for mid-July last year, but that got cancelled because of COVID. And she hasn't heard since, so she's not had that follow-up. She gets dizzy when she gets up. She's also got knee pain, both knees, which is an ongoing problem. She's getting sick and tired of that as well. It's not nice. Her feet, she said, are burning now, and she gets pins and needles. She's got very dry skin, which is why she's getting the Cetrabend cream quite a bit, and the Flexitol, she's using it. She's a bit worried about dementia because she's finding that she's beginning to get a little bit forgetful. So yeah, it's a bit of a concern. It's in the back of her mind. She is worried about it. Her current status is she lives alone. She gets tearful. She lost her husband in March to COVID-19. She's got 2 children, 8 grandchildren. Again, you know, she's getting a bit tearful now because she hasn't seen them for over a year. She does FaceTime them, but yeah, it's not the same thing, and she's on her own. She's desperately missing them. She's scared of COVID, and as a result of that, very rarely leaves the house. Shopping's done for her, prescriptions are delivered. So unless it's absolutely necessary, she doesn't like to go out. And when you ask again about is everything all right with the medicines, he said, all right, I'll tell you the truth. The indapamide, I don't take it. I order it through the pharmacy. Well, I don't order it through the pharmacy sends it. But I don't take it because it's a water tablet, and because I've already got a problem with my water, I don't want to take it because I'm scared I'm going to wet myself. Or if I do have to leave the house, you know, if there's no toilet there, I'm a bit worried about that. So that's why I haven't been taking my indapamide. Wow, that's a lot, isn't it? But isn't that typical of what we can see in surgery? It's certainly very typical of something that I would see. This isn't far off of the kind of patients that I see regularly. These are some of the issues that are flagged up to me regularly. So I think it's a very typical patient of what we can see. But that's enough from me now. Now it's up to you guys. So who would like to kick off of where they would like to start? Because I'm not going to do any more talking. I'm just going to be typing in here what you're going to tell me. So Rima, Mohammed, Bola, if you can get people going now on this case study.
So,
Can I come in?
yes, please.
So she seems to have postural hypotension.
Okay.
And she's on 100 milligrams etanolol.
Mm-hmm.
So I think there is some scope for doing something there.
In what way, Mr. Kelsey?
Either dropping it down to 50 or putting on around to something like bisoprolol.
Okay.
And can I ask, what makes you think that it's postural hypertension?
She's getting dizzy when she stands up. So it could point to something about her blood sugar, but more likely the fact that when she gets up, she's having a postural hypotension episode.
Okay, thank you very much. There's some questions coming in as well. So I'm trying to type that up and send that to you, Mohammed, as well, so you can have that. I mean, Imran, so you can have that as well.
So someone has suggested that we should be stopping the pioglitazone because of the risk of fractures and hypo in the very frail. But is there another reason?
Sorry, did you say fracture risk and what else?
Hypos and very frail.
So there's no PPI cover.
So if people are able to join the conversation, that would be better than if you're able to type it in.
Yeah, people are typing it in. There's been quite a lot here.
Yeah.
So I'm just trying to see if I can put everything into a Word document. So if people, while I'm trying to do that, those who haven't written anything so far and would like to contribute towards the this session, please unmute yourself and ask those questions. So it gives me time to type it up quickly and send it off to Imran. So you can actually include that in as well. Thank you.
So the other things that have been raised are what's the indication for aspirin, and why do we need both aspirin and rivaroxaban? What are the indications for that? And then we've also got what is alendronic acid? Been on it for 5 years. Do we stop? Is the dextra due?
He's on a lot of medication. I mean, you got 3 lots of diabetic medication, they plus the insulin, and she's not checking her blood.
Thank you very much. Is there anyone who would like to unmute themselves and also share their view as well, please?
I'm going to ask about the dose of the ramipril in renal failure as well. And if the lady might possibly have heart failure as well.
We need to chase her urinary incontinence referral.
I think most of her problems would actually be resolved or lessened if she could just lose some weight, really. What's her diet like, Imran?
It's not brilliant. It's carbohydrate rich, but at the moment her diet's a bit varied. So some days she doesn't eat a lot, but then some days she'll have chocolates and she'll have biscuits, and she'll eat crisps. So it's not a great diet.
I would query depression, stroke, anxiety.
And then
what's the reason for her non-compliance, Imran?
For which one?
What was the reason for? You said that she wasn't taking a few of her tablets.
Yeah,
what was her reason for that?
Okay, so the indapamide, because she already has issues with dribbling, and she's been told it's a water tablet, so she's worried that if she takes it, she's never going to be off the toilet.
And the other drug?
So she needs some counseling, really, doesn't she?
Yeah.
Well, does she, or do you think she's got a valid reason for not taking her indapamide?
Well, she may have a reason, but she needs counseling. She needs to take it, and then maybe on the day she's going out, she can leave it off. But as a general, she needs to continue to take it.
So one of the things I would say, because obviously in an SMR, you want your patient to be involved in the conversation. If a concern is that she doesn't want to take her indapamide because she's worried about increasing her urine incontinence, we would have to take that seriously. So instead of counseling her, you want her to think of something that might work for her. So we need to listen to her as well. So pushing an indapamide on someone who feels that it's not going to work for their lifestyle is perhaps not the best way to go.
It would solve her
Has she tried non-drug?
edema problems, though.
Sorry, someone was
Has
trying
she
to say
tried
something.
non-drug options for the? Sorry. Does she try any non-drug options for the incontinence? What has she tried for that apart from?
Nothing.
many
She
drugs?
didn't even know you had non-drug options.
Exactly. And you would
Pelvic
also
floor
want,
women
Pardon?
and losing weight.
Yeah. So yeah, no, she's not considered any non-drug options.
So that would be the thing I would be suggesting is to really, you know, explore the pelvic floor exercise and doing some lifestyle change, and that would be the thing. I mean, does she drink caffeine, alcohol?
No alcohol.
No, no alcohol.
Okay.
Tea
Caffeine?
drinker.
Thing is,
Only tea,
on
not
an
coffee.
academic basis, losing weight sounds a very good idea, and it's something that's worthy. This is an old lady who
I
already
agree.
has a yucky diet, probably doesn't cook for herself or able to get people to do anything for her. It's going to be very difficult to ask her to lose weight. You know, how is she going to do it? Practically, I think that's a problem.
Well, it depends on how motivated she is, I suppose. But then, you know, she's probably depressed because she's lost her husband. So I don't know. It's up, really. I mean, it would be sort of guided by how motivated she is.
Okay, so there's, you know, so I've sent you.
Yeah.
I've sent you a lot of response back, all the collective response I've had so far. So yeah.
Okay, thank you.
So if anyone has more suggestion as well, which is not the chat, please unmute yourself and let us know those.
Why would you reduce rivaroxaban? She's not taking it anyway, apparently.
No, rivaroxaban she was. Oh no, she wasn't.
She wasn't.
Well, she says she is, but on
last
the
prescription was
actual thing-
December.
Yes, exactly. Yes, you're right, Surinder. She said she's taking it, but actually the usage doesn't exactly back that up, does it?
See, this is one of the problems of putting elderly people onto DOACs. There is no checking, nothing.
Yeah.
And also, why is it not picked up by the pharmacy or the surgery?
Surinder, that's a good question, and you and me both know that shouldn't happen, but it does happen, doesn't it? There was something, I think, Mr. Kelsey, I think there was something so there was referral, but there was also something else somebody said. It's not on there. Okay. Oh, yes.
Heart failure.
Hang on. That's what it was. Somebody's put that on the chat.
And then we've got amlodipine might be worse than edema. Several people have said start a Dorset box. So we talked about some of the support that you could have for bladder incontinence, but the other thing I would suggest is managing peripheral edema also using non-pharmacological ways, you know. So raising your leg, that kind of thing. And then what about
Also she's sedentary, so the blood circulation will be poor because there's no muscle activity or constrictive activity.
Imran,
Mm-hmm.
why is she taking the amitriptyline?
She's not taking it.
She's not taking it.
Oh, it's an
She
acute.
didn't want to take it. Yeah, it's an acute, and she never took it.
Oh, okay, that's fine. Okay.
She didn't want to go on to sleeping tablets. She's read that they're not good for her.
Okay.
And then we've got anticholinergic burden, solacalafine. Biggerone would be a better one. So it's solacalafine and also atenolol will increase your anticholinergic.
Does anybody know what the anticholinergic burden for solifenacin is? The number?
3.
Yes, it's 3.
And atenolol is 1.
So does that put her in medium or high?
Anything above 3 is considered very high.
Anybody, any other suggestions what we can do?
Has she tried sleep hygiene measures or counselling for the loss of her husband?
Okay. So yeah, good idea. Any other things that we should be thinking about or telling the GP to do, even if we can't do it, maybe out of our remit?
Was she investigated for heart failure?
No. So there's no blood. So what would you want done? I think that was Julia, wasn't it? Was that Julia?
Yeah, it was Julia.
Okay. Julia, what would you like done for the heart failure potentially?
Well, pro-BNS,
Yes.
a
Blood test.
BNP.
So that's something we could suggest to the doctor, yeah? Okay. What else have we got going on?
So I know people mention pioglitazone because of risk fractures, but we should also be thinking pioglitazone, increasing edema, all that stuff. We shouldn't really, if we're suspecting heart failure, definitely not pioglitazone in a patient like this.
So can I just remind everybody it's contraindicated in macular edema. Patient has macular edema, so we do need to stop it, as well as the fracture risk, and also anemia.
Anemia, that was the other thing, yeah.
Yeah, shouldn't be having it if the patient's got anemia. Has the patient got anemia?
Doesn't look like it.
HB of 87, we would be investigating that as anemia, wouldn't we? We would at least want to do ferritin and hematinics generally, wouldn't we?
Yeah. So yeah. So the HB of 87, we would want to do hematinics to investigate what kind of anemia potentially it is. So we would want ferritin. B12 and folate. In terms of the anemia, who would like to hazard a guess why this patient might be anemic?
I think someone may have alluded to it before.
Go on, what was it?
Well,
Anybody?
they're on.
She actually
Yeah.
Pardon?
Is she bleeding from somewhere? Has she
Bleeding.
taken the aspirin?
Yes, she is taking the aspirin. So she's on a DOAC plus aspirin.
And no PPE.
And yeah, no PPE or PPI.
PPI, sorry, I meant that.
Okay.
And then what do
So-
people think about her liver function at the moment? And cholesterol and lipids go hand in hand with that. Anyone thinking perhaps fatty liver with the raised alanine trans? Yeah, ALTs raised, no?
She's also quite non-compliant with her statin from her EMIS usage or her prescription.
Which
usage.
probably makes it even more likely it's a fatty liver rather than the statin raising the ALT, which can also happen.
What was her triglycerides like?
Raised
3.3 or something like that.
4.4, 4.4. Oh no, 3.3, you're right. That's total
Yeah.
cholesterol, 4.4, right?
Yeah. What could be the cause of that, Jules? Anybody? Why could this patient potentially have had a rise triglyceride?
She wasn't fasted.
That's right. She wasn't
Bad diet.
fasting. Yeah. No. It's if you're
Non-fasting.
not fasting, you can have a raised triglyceride, and if you go fasting, it might be normal.
Because remembering your TGs are what's in the blood that's swimming around. That's your main lipid that's actually in the blood. So that's why you tend to get.
So the question
Raised.
arises that if it was a blood test for cholesterol, why was it taken when she hadn't fasted?
So you don't have to fast for your cholesterol. You know, we don't recommend that you have to fast, especially for diabetes monitoring or any routine monitoring. But you would consider, you know, if a raised TG, you would consider it might be because she wasn't fasting.
Now, what I
But
mean to say is,
also-
if you are sending a patient for a cholesterol test, you ask them to fast.
Yeah. Well, if you're doing a full lipid profile, you will ask for fast. If it's just cholesterol, you wouldn't. But with the full lipid profile, what I find is I actually put in bold on the form fasting, but patients are patients. And unfortunately, sometimes if she's getting an appointment at 4 o'clock in the afternoon for her blood test, she's not going to be fasting. That's the issue.
And you have to be careful with your diabetics when you ask them to fast and they're on insulin. It's a tricky business, really.
Yeah.
So sometimes you just have to work with what you've got.
Excellent. Keep them coming. Keep them coming. I hope you're enjoying this, because I am.
Me again.
Go for it.
I've just noticed the potassium level was 5.2.
Which one? Potassium, yes.
Now she is on Ramipril.
Yeah.
So what would you do if you had a 5.2?
Well, I mean, really, I think that's a
Borderline.
bit hard to be on Ramipril, to be honest.
It's
But,
borderline.
So you'd normally repeat that because you'd also want to check it hasn't just hemolyzed as well, your sample.
Yeah. What could be the causes of a high potassium, apart from being hemolyzed? Apart from any drugs, what else could cause it?
Well, a CKD patient, isn't she?
Yeah, that's potential.
Any fruit or squash in the diet, sometimes different foods can cause a high potassium.
Yeah, what else?
Maybe she's having a lot of bananas.
Yeah, well, under food, yeah. What else? I'll put you out your misery. Heart failure and also diabetes. If you've got very high blood sugars, it leaches the potassium out of the cells into the blood. Okay, so what else we got? What's our finishing time today? Because I need to make sure I keep everybody, don't keep them longer than necessary.
2:15 is the.
Okay, all right. So we've got roughly 20 minutes before we do a summary. Anything else? Okay, right. I'm going to go back then. I've put all your suggestions in, which are excellent, by the way. So let's go back to the investigations and let's have a little discussion then. So things that we haven't talked about: PCR, protein creatinine ratio of 112, which means he's leaking a lot of protein. eGFR is 33. So we need to start thinking about a referral to who? Nephrology. Okay, she's got PCR of more than 100 with a low eGFR. We need to have a discussion with the GP about getting her down to the kidney specialist, because she may be on her way to complete kidney failure. So we want to try and stop that. The way we try and stop that is by tight blood pressure control and tight HbA1c control. Now, the blood pressure is high. She's not taking her indapamide. So she's only therefore taking the atenolol, the ramipril, and the amlodipine. So she's not taking her full cohort of meds. Her HbA1c is raised, but getting hypos. So what could be the potential causes of that? Well, she's on insulin. We know she's not always taking her insulin because she's now got a poor diet and doesn't always eat, and therefore she's afraid to get hypo. But another thing that could be causing potential problems with hypos, random hypos, is hyperlipotrophy, where they inject themselves with the insulin. If they're not rotating the sites adequately, you get little lumps. So when you inject into the lump, the insulin doesn't come out properly. It can come out too quickly, it can come out slowly. So her levels may be all over the place. So we need to check for lumps on the tummy, if that's where they're injecting, or the thigh, if that's where they're injecting. That's very fundamental for every diabetes check. She's not recording her blood sugars. We need to get something done on the blood sugars. So number one, they're on acute, which means, you know, even if she does order them, it's going to end up going to the GP, so she's not going to get it on time. Therefore, if she's on the insulin, there's absolutely no reason why blood glucose testing strips are on acute, right? She needs to be checking. 50 strips is not enough. She probably needs 100 or 150 strips. We need to convince this lovely lady she needs to check at least, because she's not going to do it more than this. If she can do one in the morning pre-breakfast, 1-2 hours post-breakfast, and at least 1-2 hours post-dinner, at least it gives us some clue as to what's going on. So the other thing we need to do is we are not going to manage this patient on insulin with HbA1c of 84 and this kind of renal function in the surgery. We are going to do a endocrinology referral because they're not under an endocrinologist. So that's another thing we need to do. Let's get on to the full blood count. Platelets are okay, but he has some kind of anemia going on. What are the causes for the anemia? What are you going to ask? Is there any change in the color of the motions? Is she bringing up, has she got any epigastric pain? Has she had any weight loss? These are red flag questions we should be asking. Has she been getting any heartburn? We know she's on aspirin and she's on rivaroxaban. But we need to go to the GP. GP may want to do an endoscopy, find out if there's a stomach bleed. We can ask about the motions and that will give us a better clue. But something needs to be done there. So definitely we need to at least get the hematinics done to find out if she's anemic. We need to stop pioglitazone because that exacerbates the anemia. We shouldn't be giving that at all. She does need, for once, we're not stopping a PPI, we need to give her a PPI. Once the investigations are done for the OGD. The creatinine clearance we work, and we, from the top of my head, I think this dose is okay. The dose of the rivaroxaban is actually okay, right? The foot check showed that she's got, she's got her pulses there. She's got sensitivity, which is a little bit of good news, considering she's already got retinopathy in both eyes. But look at that date, March 2020. Guess what she hasn't done? Hasn't been for more than a year for her eye screen, which means she's probably DNA'd, which means she's not been going out. So we need to reorganize or get her to phone up the screening center and get a new appointment, because this R1 may be R2 by now. She may have developed maculopathy in both eyes. It's very important. She's going to end up going blind. So we need to find out whether she missed the diabetes eye screen appointment. Her pulse is fine. It's okay considering she's on a beta blocker. It's regularly irregular. Well, it will be. She's got AF. So we know what's happening there. Now, save that kidney. We need to control this. We're going to do a diabetes referral. We're going to do a renal referral, but we need to manage his blood pressure. Now, it's a fine balance between managing a tight control on the blood pressure. She's already, vulnerable to falls and things like that. So it's a question of trying to work out a good balance between the medicine. Can we give this patient doxazocin? Anybody? Yes or no?
You ask again?
Any doxazocin. Could we stop the atenolol and give doxazocin?
She doesn't have heart failure, yes.
Okay, but what about her incontinence? See, could be a difficult one. Now, believe it or not, in dopamide, while she has concerns about making her wee more, we actually need to find out what the problem is with the incontinence. So it may be is actually the better option, possibly. Solifenacin quite clearly not working. She was told to stop it by the hospital. They've said start her on mirabegron. Mirabegron, fine. What happens with mirabegron though in a lot of patients?
Hypertension.
It may reduce hypertension. Her blood pressure is going to go up again. So now we've got a problem, haven't we? We can stop the solifenacin. We give the mirabegron. She's already got high blood pressure. Then her blood pressure goes up even more. Plus, we've got to get her out of the house. We've got to get her into the clinic to do the blood pressure. Not an easy one. It's not working. I would definitely stop this. That may actually resolve quite a few of her issues. Now, if you look at this, she had one COVID injection. She's more than 12 weeks. What happened? Did she miss her appointment? Did she not get an appointment? We need to organize something around that. The knee pain. She's taking Flemigel. I know it's a topical NSAID, but it's an NSAID. She's got kidney disease. She's taken her paracetamol as well. What has our GP colleague done? What's he done about, or she has done about her knee pain? Has it been taken seriously? It's her concern. She hasn't given monkeys about the HbA1c because it doesn't hurt, but the knee pain hurts. So she's interested in that. So we need to speak to the GP and say, Miss May, we need to stop the Voltron Emugel. You need to sort out something for her knees. You know, whether she goes for a scan, whatever it is. I'm not a GP. It's not my job to work out what's wrong with her knees. That's your job. So we need to find out what's going on there. And if we go back to here again, yes, so we already talked about potentially a fatty liver, but we need to look at the history of ALT. Has it been up, down? What's been going on? So let's have a look at this bit here. She's tired all the time. Well, there's a number of issues. It could be the diabetes. It could be the kidney disease. It could be the anemia, shortness of breath upon exertion, but not when lying down. Maybe it's not heart failure. Maybe it's actually the anemia that's making her short of breath. So we need to investigate, not us necessarily as pharmacists. That's not our job. She's got this pitting edema. I need to speak to the GP and say, mate, you need to come and have a look at her legs. The hypos, what we need to do is we need to get her to start doing her blood sugars. I mean, how do I know she's got a hypo? She said she's got a hypo. Did she check her blood sugars? No. I've got people telling me they've had a hypo. When I look, their blood sugars are 6. That's not a hypo. They think they're having a hypo because they're used to having blood sugars of 12 and 11, 15, and suddenly it comes down and they go, I'm having a hypo, and I've had, 6 chocolate biscuits because of it. No, you didn't have a hypo in the first place. So we actually need to explore whether she is having hypos. We also need to check, and honestly, anybody can do this. You literally put your fingers over the tummy. I won't demonstrate it. You've got to have your dinner yet. You put your fingers over the tummy and you just feel for bumps, lumps under the skin. And if you find them, don't inject there. Avoid it until the lumps are gone, at least 3 months. She's got itchy skin, which is concerned her. Look how much Cetrabend she's using. Why? Why has she got itchy skin? Chronic kidney disease potentially is a reason for the itchy skin and arms. So we know she's got kidney problems. Alcohol and all of that kind of stuff. Now, we need to think a little bit more about this urinary tract problem. Constipation not going fully. Believe it or not, that can even be the diabetes. It could be lack of fluid intake because she's scared. She's scared she'll drink, she'll pee. So what do the patients do? They stop drinking, right? And that's going to exacerbate her kidney problems. I always say one thing about kidney. Keep yourself hydrated. Don't let your kidneys dry. Keep your blood pressure under control. Keep your diabetes under control. That way we have a chance to save your kidney, right? We need to find out what's going on with this. Actually, if we're going to stop the alendronic acid, so we need to go and speak to the GP and say, listen, 5 years, up to you. You want to do a DEXA, get it sorted out, but I'm telling you now, 5 years is up. You need to, my advice to you is review now whether we need an ongoing need for alendronic acid, because probably we don't. She's had no other fractures in between in the last 5 years. She fell over. She had an off. She had neck of femur fracture where she fell over and landed on her hip. That was the reason. So maybe we don't need it. And in case you're wondering why they actually get an increased risk of a fracture with alendronic acid after 5 years, very simple. Your body puts down, lays down bone in a very structured way, sort of like in a crisscross pattern, right? Alendronic acid doesn't do that. It's like a dodgy plasterer, ones that you find on the street corner. They come in and it just slaps it down. It just slaps bone down in any order. So what happens is, after time, instead of being rigid and structured, it's unrigid, it's not structured, and it becomes brittle. So you actually increase the risk. Rivaroxaban. Yes, she's got AF, she needs it. Why is she on the aspirin? I'll tell you why she's on aspirin. Because in 1991, they said everybody who's got a risk of a heart attack or a stroke should be on aspirin. And that's what's happened. She's been on it ever since. Does she still need it? Has she had a heart attack? No. Has she had a stroke? No, this is primary prevention. We know we can stop it. We definitely get that out. Now, she says she's getting worried. Look at it, dementia, forgetful, right? That could be the solifenacin. Yeah, the dizziness when she gets up is also related, possibly to the solifenacin. Is there enough of a drop in the blood pressure when they're standing up for us to think of postural hypertension? Rima, what's the percentage drop? Tell everybody. Can you remember?
Sorry, I didn't hear the question. What did you say?
What kind of percentage drop are we looking at on the difference between a standing and a sitting blood pressure to think of postural hypertension?
15 to 20, isn't it?
Yeah, 15 to 20%. If you've not had a 20% drop in the systolic, then it's unlikely to be postural hypertension. Look at this. Husband died of COVID. As she's talking to you, she's crying. She hasn't seen her children or grandchildren. What bereavement counselling has she had? Has she had any support? What about social? Somebody did mention social prescriber. She needs to get out of that house. She needs to talk with other people. She needs some kind of life, right? So again, it's not just about the medicines. This needs to be considered. Again, you go to your colleagues, you say, listen, I think she needs a referral to a social prescriber. You talk to her and you say, we can get you into a club, we can do all of these things. So there is so much to think about in this patient, and we need to definitely stop the aspirin. We definitely need to stop the pioglitazone. We potentially need to stop the atenolol, but we need to maybe convince her to start the indapamide. We need to stop the sulfenacin, see if the condition gets worse or not. We need to talk about the mirabegron, because if she's already got high blood pressure, which is knocking out a kidney, we could potentially start the mirabegron and check the blood pressure every 2 weeks, see if it starts to go up. But in my experience, probably more than 60–70% of patients who I've started on mirabegron, their blood pressure's up. And then we're having to chase around to see how we can reduce it. But it's balancing of risk. How important is urinary incontinence? Now, this is important because look, what we need to find out, we're not doctors, but we can ask, what causes your incontinence, right? Is it stress? Is it the weak pelvic floor muscles? Is it because of abdominal? Is she got blockage there or something? You know, is it urge? She gets an urge and she has to go, right? Have we even asked? All we know is that she gets dribbles. Is it due to a blockage? That's where we need, if we think it's due to a blockage, it's an overflow, go and speak to the GP. I'm not going to do an examination. I don't even know what I'm feeling for a bladder, right? That's the GP's job, right? Could it be related, believe it or not, to the diabetes? Could it be because of nerve damage that she's now got this? So I've put this in here, so you can have a read afterwards of some of the causes of incontinence, because if we get an idea that actually it's overflow, how we manage incontinence changes, right? So very important to understand what's happening. The itching, it's easy to say, yeah, she's got a bit of itching, so what? Give her some Cetroben, it's fine, we'll keep repeating it. Well, actually, itching can be liver disease, it can be kidney disease, it could be because of anemia, it could be because of the diabetes. Has she now developed a thyroid problem? Do I need to do a thyroid function test? Is there a myeloma or lymphoma going on? Yeah, not our job to diagnose. We are not doctors. Absolutely, we're not doctors. But definitely our job to bring it to their attention because it hasn't been known. Lower limb edema. We already know she's overweight. She's inactive. She sits for a long time. So probably that is the cause. It's recently developed, so probably not the amlodipine. Although I can't 100% rule it out either. There isn't really many options. What do I do? She's got chest pain. She's got difficulty in breathing, and she's got shortness of breath with exertion, or lying flat in bed. I need to talk to the doctor. If she's got fainting and dizziness with lower limb edema, I need to talk to the doctor. Coughing up blood, you know, I mean, that's common sense. If it just suddenly happened for no apparent reason, I need to speak to the doctor, right? If she's had an injury, I need to speak to the doctor. If it's one leg and painful, it's usually worse than if it's both legs. So if you've got puffiness and edema in one leg, definitely go and speak to the doctor. Don't make any assumptions of what it is. Not our job. They get told to do that. So pitting edema, which is what this patient had, these are the most common causes. And look, we've got kidney failure, we've got obesity, we've got liver disease, you know, all of these, venous insufficiency, all of these things could be contributing to the patient's pitting edema. I've got some other slides in here which you can look at yourself, which is some causes for one leg edema, causes for both leg edema, recent, you know, acute causes and chronic causes. It's just good to know. As I said, we are pharmacists, we're clinical pharmacists. It's not our job be diagnosing it, but at least we know we need to refer it. And drugs that can cause edema as well. Very quickly, end-stage renal disease, persistent itching, shortness of breath, high blood pressure, this sleep problems. This patient has all of these things, increased mental sharpness. So this is why, you know, when you see that history that the patient is loss of appetite, when you see all of this coming from the patient and you can see what the blood results are, you can see what the urine result is, you know, we need to refer this patient for urgent management of their condition. We may only be able to at best stabilize that kidney, but I'd rather stabilize that kidney at the current levels than see this patient going to end-stage renal disease and onto dialysis, because for her, that's life over. So in terms of the kidneys, what are the risk factors? So this is why I said to you before, if you have a patient with kidney problems, control their blood pressure, make sure they understand. Control their blood sugar, make sure they understand. Control their cholesterol, especially if they've got family history of diabetes and kidney disease. What is in our gift to do within the practice, and as pharmacists, we can do this really well, is control that blood sugar and control that high blood pressure. And getting that message to the patient. And by God, it works. The number of patients I said, and I'm tricky, because I do it at an ACR more than 3. I say to them, oh, you've got a bit of protein in your urine. I'm exaggerating it. What does that mean? It means your kidneys, if we don't sort your diabetes out now, they're going to be gone. That works wonders. They suddenly, you know, they've gone from HbA1c of 88, next time you do it, it's 52. Because suddenly they take their diabetes seriously. Because up to now, the diabetes doesn't hurt them. It doesn't cause any problems for them. What is that Imran going on about? I feel fine. But actually, they're not fine because they've got retinopathy, because they've got beginnings of proteinuria. And it's important that we convey that. The other thing I was going to say to you is always document that you've told patients about their complication risk with diabetes. I'm going to tell you a quick story about what happened with me. A patient of mine had 3 toes amputated and then made a complaint against me that I had not controlled their diabetes. They came to the surgery with the partner and they were livid. This has all happened because of you. You didn't do this, you didn't do that. And luckily, in all of my consultations, I have explained the risks of amputation, of blindness, of kidney failure to patient, because this patient refused to take the medicine. I can control my diabetes on my own. I don't need your help, until they got their foot chopped. then it was my fault. But because I recorded it in every single consultation, the risk of diabetes, and this is, you know, I don't want to make fun of this, but they literally didn't have a leg to stand on because I had covered myself fully in every single consultation. So please do that, and you'll be seeing a lot of diabetics, trust me. The final slide I've given you is Google this and or put this in. It's brilliant. It's the renal handbook. Any drug you want to know, which is a problem in kidney disease, it'll tell you what dose you can take at what eGFR, and it's really quick. So if somebody said to you, you know, atenolol, can I give this in kidney failure? They've got eGFR 25. I'm not going to lie to you, I don't know that off the top of my head, but if you go there, you can find it within seconds. The other thing is this for the antiplatelet and oral anticoagulants. It'll tell you when it is acceptable for a patient to be on aspirin or clopidogrel plus a DOAC or plus warfarin, and when you shouldn't be doing it. Again, very good. Actually, it was Rima that pointed it out to me when I was flustered with one of my patients. So I'm very grateful, and it's an excellent reference source. It was a bit of a whirlwind, but unfortunately, this is reality, isn't it? This patient was typical of what we might see in the surgery. I see this patient all the time, this type of patient all the time, these type of drugs all the time, this number of drugs all the time. It's not unusual. The issues raised in this case study are not unusual, but I hope we've broadened your horizons a little bit into thinking, okay, what is going on? I need to speak to the GP. And the final bit of advice I'm going to say to you is, when you've done your structured medication review and you've gone to the doctor and you've discussed their low hemoglobin and you've discussed their urinary tract, their urinary problems, you need to document that. Discussed with Dr. X, anemia, has requested for hematinics to be done, will review possible OGD, have spoken to doctor about mirabegron, was in hospital discharge letter, doctor has said stop solifenacin, trial mirabegron, or doctor has said do advice and guidance to urology, see if it's still appropriate. Whatever it is, whatever your plan is, you must document that you have spoken to the doctor. It's to protect you. You may have done it, and if you don't record it, then it hasn't been done. So always do it. I've been pharmacist longer than I care to remember, and I still document, and I still go to a doctor, and I still say, she's got constipation. As a pharmacist, I can sell lactulose over the counter all day long, and I'm legally covered. In the surgery, I'm not. I have to go to the doctor and say, she's got constipation. From my questioning, I don't think there's any bowel obstruction, but it's up to you. Do you want me to give it or not? And the doctor says, yeah, give her some lactulose. I document, I have spoken with Dr. X, lactulose prescribed. We are right at the end of our time slot. You have been fantastic. Good feedback, excellent. We will get this presentation off to you. I thank you all. This was, you know, I've enjoyed this, and I hope you have found this useful. Please do the feedback. It's really important for us, because if there's room for improvement, we will do our best for you. And it's also encouraging for us if you did find it useful. You know, it little bit does go a long way sometimes. You know, even if one person says, yeah, actually I found it quite useful, it's nice to know. So all that's left for me to say is thank you, and Rima, Mohammed, and other members of the team, if there's anything you want to add.
Imran, you've done an amazing job. Well done.
Well, it's all thanks to you guys. Just to remember, next session, 1 week later, it's going to be on the 26th of July. COVID vaccinations, I'm afraid, are taking up our time at the moment. So regrettably, we've got to push it back a week. Please encourage your colleagues if they haven't attended. It's nice for all of us as clinical pharmacists and primary care pharmacists to get together and share our learning and share our experiences. there any final questions? Please do ask. Otherwise, I'm going to say thank you very much to all of you.
Thank you.
Thank you, Mr. Kelsey.